Jeszcze raz, czy mamy może połączenie z panią doktor Elżbietą Tabor?
Tak, jestem.
Super, bardzo cieszymy się z obecności pani doktor. Od tego momentu ja przejdę na język angielski i będziemy mogli rozpocząć. So, we'll start. Esteemed jury, dear participants, listeners, ladies and gentlemen. On behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in the National Medical Conference Silesia 2025. My name is Michał Azierski, and together with Aleksandra Sowa, she will come soon, we have the honor of moderating this session of systematic review and meta-analysis number 2. I would like to explain the rules of this session. The order of the presentation will be the same as it is in the abstract book. The maximum time for presentation is 7 minutes, and the time for the discussion is 3 minutes. If the presenter exceeds the time, he or she needs to move on to the conclusion and finish the presentation as soon as possible. I would like to kindly remind you that if you are the that's the information for the jury. I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross the number on your card. Other members of the same clinic are able to assess the presentation. The assessment will be verified. And the jury will assess your work in four different categories: scientific value from 1 to 5, way of presentation, discussion, and own contribution. When the session will end, I ask the jury to give back their cards, and we will verify them. So that's all from this organization information. And from here, I would like to invite on the stage the first author of the work titled Comparison of Different Pedicle Fixation Methods in Congenital Scoliosis, Bayesian Meta-Analyses. Yes, we have the author of this work. Ladies and gentlemen, please welcome every author with their great applause on the stage.
Good afternoon. Thank you for this warm invite. My name is Paweł Łajczak. I am third-year medicine student from the Faculty of Medical Sciences in Zabrze. And together with Genero International Research Group, we prepared this Bayesian network meta-analysis. Congenital scoliosis is a complex spine deformity affecting younger patients. A proper treatment strategy is needed to recover their spine function and quality of life. pedicle screw instrumentation in posterior approach is a common fixation method which is used in the treatment of the congenital scoliosis. However, traditional freehand guidance, which relies on the anatomical landmarks, can be prone to the errors and potentially lead to the misplacement of pedicle screws, damaging blood vessels or leading to nerve injury. Various navigation techniques are being developed. These include preoperative spine models, drill guides, robot-assisted surgery such as ROSA, or computer-assisted surgery such as Maser. However, currently, there is no systematic review comparing these novel navigation techniques to traditional freehand-guided surgery. The aim of this network meta-analysis is to compare these 4 novel and 1 traditional freehand-guided method into the management of the congenital scoliosis patients. We followed PRISMA and Cochrane guidelines with a network meta-analysis extension, and we included studies which provided a comparison of at least 2 different techniques, and we searched 5 databases. Keywords in the database search were related to these techniques, along with the congenital scoliosis. The screening and data extraction was performed by 4 independent authors, and primary outcome of interest was Gertzbein-Robbins pedicle screw accuracy. Grade 0 is considered perfect placement. Grade 0 and 1 is considered clinically acceptable and safe for patient, while grade 3 is considered a severe misplacement. This study employed a Bayesian statistics framework in network meta-analysis. We applied non-informative priors and random effects model to compare the 5 different models. And evidence was, the studies included in this evidence were assessed in terms of quality with Robbins Cochrane tool. After a comprehensive search of nearly 4,000 articles, this study and review included 11 studies in the network meta-analysis. Here's an example of an outcome we compared going clockwise. Anatomical models, robot-assisted surgery, navigation-assisted surgery, traditional freehand surgery, and pedicle guides. Most of the papers compared anatomical models to freehand surgery. And there were over 500 patients and more than 5,000 pedicle screws. The insights of this meta-analysis are as follows. Interestingly, spine models showed significantly higher odds of fully accurate screw placement compared to freehand. Moreover, all techniques showed significantly higher odds for placement of clinically acceptable screws, so grade 0 and 1. Computer navigation surgery showed significantly longer operation time compared to 3D printed drill guides. However, while the pedicle screw accuracy was improved, there were no significant differences in terms of blood loss, coronal cup angle change, offset, screw placement time, hospital stay, correction rate, or fluoroscopy use between the techniques. Here's the example of league table from our network meta-analysis. In bold, we have significant comparisons. As shown, all techniques had significantly higher odds of placement of clinically acceptable screws compared to traditional freehand. However, other comparisons were insignificant. Assessment of quality showed some concerns in the studies, especially due to confounding, selection of participants, measurement of outcomes, or selection of reported results. However, in terms of Bayesian statistics, there was no difference in terms of direct, indirect, or network evidence, along with trace plots, which showed good consistency of Bayesian network model. And here's a summary of the outcomes. In the green, there is the best treatment for each outcome. This is a summary under cumulative ranking area applied in the Bayesian statistics. As shown in the table, 3D printed drill guides showed the highest efficacy in most on the outcomes, for example, in the operation time, blood loss, screw placement time, or coronal cup changer. Conclusions are as follows. These novel techniques are safe and provide higher clinically acceptable screws compared to freehand. However, while screw accuracy was improved with these techniques, this did not translate directly into significant difference in terms of clinical outcomes. Furthermore, this study was confounded due to retrospective design of the studies, as we did not encounter randomized trials and a risk of bias showed concerns. This study did not also compare the cost effectiveness, which plays an important role as robotic surgery is very expensive. Furthermore, the study is limited by a relatively small number of studies, and there were often no direct comparisons available in the literature, for example, between freehand or robot-assisted surgery in congenital scoliosis patients. Thank you very much.
Thank you very much. Do we have any questions from the jury? Yes, I will come down. Yeah, but we like to hear you online.
Okay. At first, I would like to thank you all students who joined this session. We hope all our colleagues is from one Department of Epidemiology in Katowice. I think Dr. Tabor, yes, is with us. It was from which department?
Yeah, hello, I'm from Internal Medicine and Diabetology in Zabrze.
In Zabrze. Okay, so we have both faculties. It is, I think it is interesting session. I have a question for the author. Could you tell us from which department you are and why you are interested in scoliosis and this topic? Could you tell us?
Thank you very much for the question. To be honest, while I am generally from biophysics department, the work was done outside the Medical University of Silesia and with international group, which consisted in this study from students from Turkey, Brazil, and more. So we collaborated on this project. And regarding the scoliosis, that generally spine surgery is something I really enjoy.
May I have a question as well? Thank you for that introduction, Professor Kowalska. My name is Kamil Barański, and my question is related to impact of authors to the work. So could you tell us how much effort each author input into this work? Because the quality of the work seems to be on really high level. And it's not that I do not believe in the skills of students, but the analysis, the time which it's needed to realize such work, it's really huge. So could you please express maybe in percentage, or maybe you could express the role who participated in this work?
Thank you very much for the question. This study consisted of several authors who all, I believe, contributed a lot in the project of this study, as we had over 4,000 records to screen, which consumed a lot of time. Generally speaking, I was the first author and the leader of this meta-analysis, and I developed this idea after consultations with spine surgeon and neurosurgeon. I generally developed the idea, performed the study screening for the meta-analysis. I also participated in data synthesis because of my skills in R software. I developed Bayesian model and performed the statistical analysis. I also performed the writing for the study and visually performed figures for this analysis.
Okay, which software have you used for the meta-analysis?
I used R software with GemTC package.
Thank you. No, thank you.
Thank you very much for your presentation. And esteemed jury, we will skip the presentation number 2 and the number 3. This presentation will come back at the end of our session. So now I would like to invite to the stage the author of the fourth presentation for work, titled Cutaneous Close to Hematological Malignancies, a scoping review of dermatologic science in leukemia and lymphoma.
Hello, everyone, and good afternoon. My name is Islam Khalil. I'm a sixth-year medical student at the Medical University of Silesia, and today I'll be presenting to you our scoping review titled Cutaneous Clues to Hematological Malignancies. It was co-authored with my friend Bashirat Abdurrahim, and our supervisor is Dr. Agnieszka Kimak-Piras from the Department of Dermatology at the Medical University of Silesia. So I would like to start to introduce our topic. As we all know, the skin can be a mirror to a lot of systematic diseases in general. Specifically here, we would like to talk about hematology and hematological malignancies. They often present with a lot of cutaneous manifestations that we might unfortunately ignore. These specific lesions might serve us as early indicators, sometimes before even the proper diagnosis is even established. Next, please. Second, the aim of the study was to assess the evidence linking us to cutaneous manifestations, and our main focus is about leukemia and lymphoma, the diagnostic and prognostic values, and also we wanted to map out proper evidence linking the role of dermatological assessments to early detection of a lot of malignancies, especially hematological ones. So we searched PubMed, Scopes, and Web of Science in between the years of 2005 and 2025, and our inclusion was specifically on studies that studies and also case reports that described the cutaneous manifestations only involved in leukemia and lymphoma specifically, and we excluded anything that is not related to that, like non-hematological or non-cutaneous ones. This is our main focus as well, and I'll be going through it. So the results actually included 34 studies. We established common findings in those, and these are the two lists of the common skin findings. For example, we have leukemia cutis, petechiae, and also we can see also even simply jaundice. And the common malignancies are, for example, like AML or CLL as well. Also in here, I have a summary of the key cutaneous manifestations that I'll be discussing, specifically the ones linked to leukemia and lymphoma. And we can see also, for example, we have reticularis that is strongly linked to multiple myeloma, and jaundice can be just in general, just to assess the advancement of any malignancy. The first one that I want to discuss is petechiae. They usually look like small pinpointed non-blanching spots. They're less than 2 millimeter in size. However, they're strongly linked in general with thrombocytopenia and specifically in leukemia as well. The second one is bullous pyoderma gangliosum. These are shallow and painful ulcers. They have grayish or bluish borders, and they're very frequently seen in AML and other myeloproliferative diseases and thrombocythemia. The third one is leukemia cutis, and in my opinion is one of the most important ones because it is linked to the advancement of the disease and sometimes poorer prognosis. It is frequently seen as simply papules or nodules that show on the skin, either on the trunk or on the other parts like upper limb. And they're also strictly linked to T-cell lymphomas. When we can now switch gears to lymphoma. Lymphoma is usually specifically characterized by rashes. And here we can see a rash that can look unusual, do not resolve, and seen in 50% of angioimmunoblastic T-cell lymphoma patients. You can see how they can look either diffused in figure A, or they can also look patchy and lacy in nature. The second one is also a rash, but it looks really different. It's scaly and erythematous. It is strictly characterized to the feature of mycosis fungoides, and also very linked to T-cell lymphoma as well. In here, I would like to pinpoint about the that these rashes look like eczema or psoriasis. That's why it's very important to pay extra attention to them. The third one is just nodular patches or raised patches that are also linked to mycosis fungoides. And the fourth and last one is erythematous papules. These might look really innocent and viral in nature, however, they are not, and they're strictly linked to large cell lymphomas. So in here, I would like to just discuss the implications. Specifically, I would like to really talk about the importance of collaboration between dermatologists and hematologists. And the main and major knowledge gap that we found in this study is the lack of cross-specialty training and the lack of a standardized systematic evaluation of dermatological signs in general. These are the prognostic clues. It's a summary of them. I would like to just talk briefly about the pruritus and its importance, especially in Hodgkin's lymphoma, because it can be linked to the advancement of the disease, and it might precede systematic symptoms. When it comes to jaundice, it's also might indicate hepatic involvement, and ulcers, non-healed ulcers or infections are usually reflect immunosuppression. As a conclusion, I would like to say that dermatological manifestations provide key diagnostic and prognostic insights. The early recognition of these signs, especially when it comes to the timely intervention, it improves patient care. It also leads to better outcomes in general and even better costs. The collaboration with between dermatology and hematology is also paramount, specifically to actually evaluate the disease and understand how to manage it. And I would like to also call for a standardized guideline for all clinicians to have in hand to see and actually assess the skin properly before making any other prognosis. And these are our references. And thank you so much for listening to me today. And I will be receiving any questions you might have.
Thank you very much for this presentation. Do we have any questions from the jury?
You shall ask. Could you show us again the list of your bibliography?
Yeah, the references.
This is all.
These are just the images. Yeah, I failed to mention that. These are the images that we used in here, but the whole list of references is in the paper.
Okay. And I have a question for you. I think it will be useful for future medical doctor, this kind of analysis. But could you tell us leukemia, how often happened leukemia in the population? This is the first question. What is the frequency of leukemia? Okay. And the second question, which one of signs you presented this day is most frequently occur patient with leukemia?
I mean, I have a really brief experience as I'm still a student. However, I believe leukemia is very, very relevant, especially in the older generation. And also sometimes in even pediatrics as well. However, I do not have a proper stat of it, so I cannot just say it. And the most, I think, important sign is simply petechiae, because as I remember during the rotations, I've seen a lot of patients having leukemia, actually having petechiae at any stage of the disease. So, I mean, I couldn't tell you. Yeah, I would say that, yeah.
Leukemia is not very often happening to this. This is rare disease.
Yeah.
Yeah, I have a question as well, because that's a very important point, which was mentioned by Professor Kowalska. So I felt like you gave us an interesting lecture, and it's not very much corresponding with the review, because we couldn't even see the number of papers that you reviewed. And in one of the results that you shown the symptoms, which should be correlated with specific leukemias, etc. That would be great if you could show the number of papers of which were
How many papers?
Papers which were showing the changes of the skin in the specific, I don't know, leukemia or something like that. Yeah.
Okay.
So that for me it was confusing, because you just mentioned strictly some specific symptoms, while you didn't give any feedback from the literature review, right? Because I felt that this is what was missing, in my opinion, that you didn't give the number of papers that was expressing the symptoms, right? For the specific, I don't know, stage. I don't know how to say it, but
yeah, I think.
Thank you.
Thank you so much.
Thank you very much for this presentation.
I spend time. Okay. So like around a year, and me and my friend, we just worked in like half, 50%. Each one of us contributed in the work. Yeah.
Thank you very much. Now we are moving on to paper number 5, Neuroimaging Insights, Brain Changes in Asymptomatic COVID-19 Patients Using Advanced MRI.
Yeah. Hello everyone, my name is Kenchao Cynthia Chizoba, and I'll be presenting brain alteration in asymptomatic COVID-19 patients using the advanced MRI techniques. And I'm a student of Kyiv Medical University, and my work tutor is Associate Olga. So introduction, as we know, the SARS-CoV-2 coronavirus pandemic has accounted to up to 15% cases. 15 million cases with neurological manifestation being documented of 36% in patients with COVID-19 virus. Then we have the central and peripheral nervous system complications has been reported, such as headache, cranial neuropathy, myelitis, stroke, and various neuropsychiatric manifestations. But the direct viral neurotropism has rarely been reported. Neurological complications of COVID-19 contributes to early mortality and long-term effects that significantly reduces the quality of life of patients, thereby highlighting the importance of this review. So during the review, we were able to investigate subclinical changes seen in the brain using MRI advanced techniques. Materials and method, we conducted a thorough literature review using PubMed, ResearchGate, Google Scholar of articles published within the last 5 years. So, COVID-19, it triggers hypercoagulable state through cytokine-induced inflammation. What happens here is, during the COVID-19 invasion into the cell, it causes an immune response release, thereby triggering increased release of cytokines like the TNF alpha, the interleukin 6, and interleukin 1 beta. What happens here when it triggers the interleukins, they cause inflammation in the cells. Then during this inflammation, there can be formation of clots. Then the platelet activation and endothelial damage via the ACE2 receptors. When during COVID-19, the ACE2 receptors bind to the endothelial cells and causes cell injury. During this process, the endothelial cell loses its antithrombotic factor, thereby making an increase in clot formation. And this can also lead to microvascular thrombosis, whereby the interleukins induces inflammation, and then there is endothelial damage. This then leads to microthrombotic vascular thrombosis, and then causing ischemia, decreased blood flow, and increasing the risk of stroke in the individual. So here, I and my team was also able to conduct or go through a review by Jasmine Shen, which also states the percentage, showing that asymptomatic patients with COVID-19 shows less cerebral manifestation, unlike clinical COVID-19 cases and prothrombotic markers. Then we have a case here which we are able, using the MRI techniques, we're able to show the changes. So here, please, can you remove this? Thank you. So here, the foci A shows microangiopathy in the white section here. Sorry, yeah. Where? Okay. So, or we can use the arrow. So here, we can see like the white matter of the brain. It shows microangiopathy. Moving to the B section, we can also see here, pointing to the image, we can see the projection of stroke in the hypothalamus. And then the D, it shows ulceration in the right hemisphere of the cerebellum. Then E also shows hemorrhagic infraction in here. So for case 2, this patient also had a history of hypertension, but after MRI conduction, So during MRI conduction, we were able to see in the B section an hemorrhagic infraction here. So during the course of this research, we're able to conclude, or during the review, we're able to conclude that different patients showed different symptoms or different neurological symptoms when having COVID-19. And despite the symptomatic effects of COVID-19, the neurological manifestation still remains much relevant. Thank you.
Thank you very much for your presentation. Do we have any questions from the jury?
I see different cohorts. Just can you repeat? Sorry. In the image? Okay. Okay, so what happened here, this is a conclusion from this author. Yes, from one publication. Okay, so we use the Google Scholar, the PubMed. So doing this, we included articles or review that had neurological manifestations of the brain changes in the MRI. And then we also excluded reviews that had just symptomatic effects in the brain.
Thank you very much for your presentation. And now I would like to welcome on the stage the author of the sixth work, the work titled the BDNF and GDNF in Parkinson's disease, associations with symptoms, disease, course, and progression. Yes, big applause. Just give me a second.
Okay, so good afternoon. My name is Patrycja Chudzińska, and I'm a member of Neurology Student Scientific Organization in Medical University of Silesia in Katowice. It is my pleasure to present to you the systemic review titled BDNF and GDNF in Parkinson's disease, associations with symptoms, disease course, and progression. This presentation will consist of the following: introduction, materials and methods, results and discussion, and finally conclusions. Let me briefly tell you about what these two neurotrophins are. BDNF, brain-derived neurotrophic factor, and GDNF, glial cell-derived neurotrophic factor. These are proteins that help our brain and growth, development, and survival. BDNF plays a crucial role in brain functioning, such as learning and memory, and GDNF is responsible for nerve regeneration. We did a systemic search of 4 databases: PubMed, Scopus, Web of Science, and Bayes, inclusion and exclusion criteria. Finally, we found 33 studies to further exploration. These tables show the details of the process of article selection. For bias assessment, we use Newcastle-Ottawa scale. Now briefly about inclusion and exclusion criteria. So we found researchers evaluating changes in BDNF and GDNF concerning disease severity, duration, and both motor and non-motor symptoms, and we excluded incompatible ones. We found observational studies, and we excluded other type of studies. We qualified articles available in English or Polish language. These diagrams show which kind of neurotrophin were used and also what was the biological material. The most important thing, results and discussion. We divided our articles into 4 categories: motor symptoms and disease progression, neuropsychiatric symptoms, other non-motor symptoms, and other associations, metabolic effects. The first section is about motor symptoms and disease progression. We had here 16 studies. They were all about changes in BDNF and GDNF levels in relation to age at onset, disease duration, and treatment parameters. Let me tell you about the most important articles. The first one, Chang et al. In 2020, they showed that lower plasma exosomal BDNF levels correlated with more severe axial motor symptoms, such as postural instability arising from the chair and gait impairment, assessed in UPDRS part 1 to 3. These 2 articles are mostly about the same, but I want to draw attention to the article Huang et al. In 2019. They demonstrated that patients with L-DOPA medication presented higher BDNF compared to those without L-DOPA. Article Huang et al. In 2018, they proved that also what we know, that BDNF level in early stages is significantly lower compared to mean BDNF in healthy controls, but also similar outcome that BDNF level increased with the increase of disease duration and L-DOPA treatment. These articles are a little bit different. For instance, Roja et al. In 2018, they analyzed that there was no significant difference between PD patients and controls regarding the plasma levels of the evaluated neurotrophic factors. And Ventriga et al. In 2013, they showed that BTN levels were increased compared to healthy controls, but they did not compare between PD with L-DOPA treatment and without L-DOPA treatment. What can be wrong? Conclusion. The second section, neuropsychiatric symptoms. We had also here 16 studies. They were all investigated the relationship between BDNF and GDNF and various neuropsychiatric symptoms. This particular study are showing that there is a link to motor symptoms. So Hang et al. In 2020, they revealed that BDNF levels in PD with depression were significantly lower than in those without depression. This study is showing a link to cognitive function. For instance, Leverance and all in 2011, they indicated that BDNF in cerebrospinal fluid was correlated positively with digit symbol performance. These two studies are showing that there is no link to depression. For instance, Caso et al. In 2009, they showed that BDNF levels did not correlate with BDI score used for depression. And these two are showing that there is no link to cognitive function. For instance, Bad et al. In 2024, they indicated that serum BDNF showed no statistically significant correlation with the neuropsychiatric assessment. What is also vital to know that GDNF can be used as a marker of cognitive decline. This is about article Leo et al. In 2024. They exposed that the serum GDNF level was significantly lower in PD mild cognitive impairment compared to PD without this impairment. The third section, sorry, can you just, because I... Thank you very much. Other non-motor symptoms, only two sentences here, that BDNF serum is lower in patients with PD and restless leg syndrome, and that GDNF is lower in patients with PD and constipation. Okay, thank you. And the last one, other association, we did not find any conclusions here. Korkamas et al. In 2024, they showed that there is no statistically significant conclusion, so there is no link between metabolic effects and neurotrophic concentration. Let's move to key results. First of all, some studies associated lower BDNF levels with more severe symptoms, longer disease duration, and poorer functional test results. Increased BDNF in advanced stages may be due to the influence of dopaminergic treatment. A reduced level of BDNF was also found in PD patients with depression, and GDNF shows limited associations with motor function, but clearly declines with cognitive impairment progression. And conclusions. BDNF and GDNF in serum levels, blood components, and cerebrospinal fluid has shown various associations with PD symptoms. These include motor symptoms as well as cognitive, mood, and autonomic nervous system dysfunction. Studies suggest that the levels of these neurotrophins decrease as the patient's overall clinical conditions worsen, highlighting their potential as biomarkers for disease progression and symptom severity. And this is everything. Thank you for your attention.
Thank you. And do we have any questions from the jury?
Yes, congratulations. Well done. A really interesting presentation. I have a short question, because you suggest that you look at the English and Polish articles. We couldn't see any Polish language article. It means we have no this type of study in Poland?
Yes. Yes, we only had English articles. All 33 studies were in English.
I have a question as well. So while you were reviewing those papers, maybe you realized what could be the limitation of those papers.
Of those papers of the use of BDNF and GDNF?
those papers, because I think that I found the limitation in
Okay, so
relation, but I'm just wondering.
Mostly they are cross-sectional.
Yeah, but
there is some heterogeneity. As far as I know, that we had, for instance, a different biological material. It can be one thing. But we did this paper descriptively other than quantitatively. So I think we'll deal with that.
What about the number of participants in each study? Because the first paper that you shown, it was like 160 patients included. The other papers did not include such, I don't know if I can say, huge number of patients, because we are talking about Parkinson's disease, especially that the first paper was from China, right? So it's a huge population. So 160 patients, it's not, something that impresses us.
I don't know such data. We will discuss this in our paper, but I don't know how much patients it was in this, so I cannot answer you this question. Sorry.
So the final question: what was your contribution into this paper?
I collected data from qualified studies, and I also was co-author of the manuscript, and I prepared this presentation.
Thank you very much. Next author will present the presentation online. It is entitled Sildenafil as a cause of sudden cardiac death, factors and clinical circumstances characteristics.
Good afternoon. Can you hear me? Can you see me?
Yes, we can see you and we can hear you.
Great. Then I am going to
I will just point the camera towards the jury and the listeners, so you can see us. We still can see your presentation. Just share your screen with us.
I try to show the screen. However, this is the first time I'm displaying.
In the middle of your screen is the big green button.
Yeah, I know. Okay.
And you should.
I try this. Okay.
So maybe we will skip your presentation and come back to it at the end. Will be okay?
Maybe not at the end.
So
I'm still trying to figure it out.
Yeah.
Sorry for that.
Yeah. Yes.
Okay.
So nonetheless, let's keep your presentation. We'll come back to you later.
Okay, sorry.
Because of the technical difficulties. And we will go to the presentation number 8, the role of non-steroidal anti-inflammatory drugs in dental practice. Please welcome the author of this work on the stage.
Dzień dobry, Szanowni Państwo. Nazywam się Kamila Żabińska. Jestem studentką 4. roku farmacji na Śląskim Uniwersytecie Medycznym w Katowicach. Dzisiaj zaprezentuję pracę pod tytułem Rola niesteroidowych leków przeciwzapalnych w praktyce dentystycznej wraz z moimi kolegami z koła naukowego pod opieką pani profesor Doroty Wrześniok. Dobrze. Celem badania była ocena potencjału wybranych substancji leczniczych w kontekście farmakoterapii w przypadku nowoczesnego podejścia do leczenia bólu w stomatologii. Materiały i metody przedstawione są na tym slajdzie. Pozwolę sobie przejść do kolejnego slajdu, gdzie jest wyświetlony cały schemat Prisma, według którego nasza praca została przygotowana. Przechodząc już do pracy, ból jest podstawową przyczyną, dla której pacjenci zgłaszają się do gabinetów stomatologicznych. Dlatego też dla lekarzy dentystów tak ważne jest prawidłowe jego diagnozowanie w celu ustalenia prawidłowego schematu leczenia. Tutaj praktyczna przydaje się metoda 3D, która obejmuje diagnozę, leczenie stomatologiczne, które obejmuje głównie leczenie przyczyny bólu, a następnie wprowadzenie leków. Jeżeli chodzi o ból w stomatologii, wyróżnia się 9 podstawowych mechanizmów powstawania bólu. Jest to ból wywołany pod wpływem na przykład bodźców mechanicznych, chemicznych, termicznych, który ustaje po zakończeniu działania bodźców. Następnie mamy przedłużony ból wywołany. Jest to w zasadzie ten sam rodzaj bólu, który został wymieniony w punkcie pierwszym, natomiast tutaj ból nie ustępuje po zaprzestaniu działania bodźca. Ból spontaniczny, który pojawia się bez wpływu zewnętrznego bodźca i wskazuje on najczęściej na zapalenie miazgi lub tkanek okołowierzchołkowych. Następnie mamy ból ciągły, to jest ból, który jest w zasadzie przewlekły, powstaje on wskutek różnych chorób i występują w nim okresy remisji. Mamy również ból nocny, który jest tak nazwany, ponieważ pojawia się głównie w przypadku pozycji leżącej w wyniku zwiększonego przepływu krwi. Ból pulsujący, który w zasadzie, jak sama nazwa wskazuje, ból świeży to jest tak nazwany jest ból, który powstał pierwszy raz w danym miejscu. Ból ostry i jest to właśnie ten ból, na którym warto się skupić, ponieważ on najczęściej jest przypadkiem, w których pacjenci zgłaszają się do gabinetów stomatologicznych. Mamy również ból promieniujący, który pojawia się w okolicach twarzy oraz zębów. Może też promieniować na pozostałe obszary poza twarz, na przykład nawet do szyi. Jeżeli chodzi o leczenie bólu, tak ważne jest właśnie, jak wcześniej wspomniałam, zlokalizowanie przyczyny tego bólu, ponieważ należy pamiętać, że leczenie farmakologiczne nigdy nie powinno zastępować leczenia dentystycznego. Najpierw powinno się leczyć po prostu przyczynę tego bólu, a dodatkowo leki po prostu stanowią dodatek do tej terapii. Dlatego, że ból w okolicach zębów najczęściej spowodowany jest powstaniem stanu zapalnego, używane są takie leki jak właśnie niesteroidowe leki przeciwzapalne, takie jak na przykład ibuprofen, ketoprofen, naproxen czy właśnie kwas acetylosalicylowy, a także paracetamol oraz antybiotyki. Natomiast niesteroidowe leki przeciwzapalne są chętnie wybierane ze względu na ich działanie przeciwzapalne oraz przeciwbólowe w porównaniu na przykład do paracetamolu. Jeżeli chodzi o podanie tych leków, to stosowanie ich na pacjentach udowodniło, że miejscowe podanie leków przeciwbólowych może być równie efektywne jak ich podanie doustne, przy czym ma ono kilka zalet, takich jak na przykład eliminacja rozkładu leków w przewodzie pokarmowym, w związku z czym eliminujemy możliwości interakcji z innymi lekami oraz z pożywieniem. Oprócz tego mamy również mniej działań niepożądanych oraz przynosimy pacjentowi szybszą ulgę w porównaniu do podania doustnego. Kwas acetylosalicylowy, czyli wspomniany już wcześniej inaczej aspiryna, znalazł zastosowanie w leczeniu parodontozy ze względu na zwiększenie produkcji wyspecjalizowanych mediatorów stanu zapalnego, tak zwanych SPM-sów. Ponadto ma przeciwzapalne działanie oraz ochronne na kość. Oprócz tego podanie kwasu acetylosalicylowego do jamy ustnej w takich okolicznościach ma również pozytywny wpływ na mikrobiom jamy ustnej, przez co zapobiega rozwojowi na przykład nowotworów jelita grubego. Oprócz tego aspiryna przez to, że ma działanie przeciwagregacyjne, znalazła zastosowanie w modulacji komórek miazgi zęba. Dawniej można powiedzieć, aspiryna była używana z chlortetracykliną w przypadku opatrunków u pacjentów seropozytywnych HIV, aby zmniejszyć takie doznania bólowe oraz przynieść szybszą ulgę pacjentowi. Oprócz tego w klinice stomatologicznej w niektórych zabiegach również stosowane było połączenie aspiryny z kwasem mefenamowym. Natomiast obecnie aspiryna jest uznawana za głównie za najbardziej efektywny, jeden z najbardziej efektywnych leków w na przykład procedurach ortodontycznych. Przechodząc do wniosków, warto pamiętać, że ból jest głównym powodem, dla którego pacjenci zgłaszają się do gabinetów stomatologicznych. Może on wynikać z toczącego się stanu zapalnego, dlatego konieczne jest prawidłowe jego zdiagnozowanie w celu ustalenia prawidłowego leczenia. W tym przypadku używamy pomocniczo środków takich jak niesteroidowe leki przeciwzapalne, antybiotyki czy paracetamol. Kwas acetylosalicylowy jest tutaj ciekawym przypadkiem, ponieważ wywiera on działanie bezpośrednie, które wynika z jego działania przeciwzapalnego, przeciwagregacyjnego, które mają zastosowanie na przykład w procedurach ortodontycznych oraz w różnicowaniu komórek miazgi zęba, ale także przez działanie pośrednie wpływając między innymi przeciwnowotworowo ze względu na inhibicję tworzenia biofilmu, a także działając również przeciwzapalnie i ochronnie na kość przez produkcję wyspecjalizowanych mediatorów stanu zapalnego. Tutaj nasza literatura użyta do prezentacji i dziękuję za uwagę.
Bardzo dziękuję za tę prezentację. Thank you very much for this presentation. I would like to inform all the participants that this session is the session of systematic review and meta-analysis. Your presentation and your work must be the systematic review. The normal reviews are not suitable for this type of conference and session. So that's the information for the participants, for the authors, and now I would like to give the voice to the jury.
No, if I ask in Polish or in English, what you prefer?
How you want, actually. I can speak in Polish. I can try to speak in English, so...
Okay. What is the key point? You suggest that you present results of particular chosen drugs. What is the key point to choose this one, aspirin, and the why?
Okay, so the main cause, it's we done this presentation to show people who might not know that they must actually choose a good drug. For example, the paracetamol, it don't has the anti-inflammatory mechanism of action. So we cannot use paracetamol to heal the inflammation. Yeah, what is the main cause of the actually dentistry pain, stomatological pain? Actually, we wanted also to inform everyone that the drugs should not be treated as the main treatment of some causes. They only should play a supportive role, because I know that in Poland especially we have a lot of people. To były najczęściej wybierane przez ludzi leki, które udało nam się znaleźć. Wiele badań na to wskazało, więc można tak to zakwalifikować.
Maybe I have a request for the people who are gonna present. It would be great if we could know what is your contribution into the work. Should be, because we have to assess that in our card formula. So please mention that always so we do not have to ask about that.
Okay, so maybe I will do this also. The contribution of this work. We worked like in six people worked on this work, but actually the main contribution like role was to split the 900 articles what we found in the beginning after the keywords like dentistry, dental pain, and non-steroidal anti-inflammatory drugs in PubMed in ResearchGate. Then we split the results by each of us, so everyone has like around 100 of work to prepare. And maybe, maybe I will show this to you because it's named in this Prisma work. Then yeah, we rejected the works what was duplicate, what like the we don't like them. So for example, it was not satisfying for us, and then we take the 8 articles what was used in this presentation.
So I don't understand why you haven't presented that.
Okay, Okay, thank you for this question. I will answer. I didn't prepare in English. That's why me with my group, we prepared the present in Polish. And actually, we didn't want to switch the language for, you know, the last moment to present in English. So that's why we use the Polish language. But we know what it means. So yeah, thank you.
Thank you. Thank you very much for this presentation. And now we will go to the next presentation, the next work titled Original AI Model to Support Analysis of Research on Vitamin B12 and its Deficiencies. Please welcome on the stage the author of this work.
Dzień dobry Państwu. Dzień dobry Państwu, ja nazywam się Szymon Małek, jestem członkiem Studenckiego Koła Naukowego przy Katedrze i Zakładzie Chemii i Analizy Leków Wydziału Nauk Farmaceutycznych Śląskiego Uniwersytetu Medycznego w Sosnowcu i pragnę Państwu przedstawić wyniki naszych prac nad modelem sztucznej inteligencji, mając za zadanie wspierać badania na temat witaminy B12 i jej niedoborów. Sztuczna inteligencja jest narzędziem, którego coraz częściej korzystamy, zarówno w pracy codziennej, jak i też nad pracą nad badaniem i rozwojem. Jednakże musimy mieć świadomość, że może ona popełniać błędy. Takim klasycznym jej błędem jest to, że kiedy nie zna odpowiedzi na dane pytanie, to tworzy się pewna luka, która jest zapewniana treścią i ta treść niekoniecznie musi być zgodna z prawdą. I kiedy pytamy się tą sztuczną inteligencję o źródło swojej wiedzy, to ona to źródło podaje. I co gorsze, przy tym, że jest bardzo przekonywująca, to trzeba być często ekspertem w tej dziedzinie, żeby faktycznie wyłapać pewne nieścisłości i pewne błędy. Jednakże nie możemy ignorować potencjału sztucznej inteligencji w badaniach naukowych, ponieważ ma ona świetne umiejętności szukania informacji w dużych bazach danych, także może wskazywać nam kierunki dalszych prac, które mogą być owocne i w tym celu stworzyliśmy i wytrenowaliśmy model sztucznej inteligencji, który ma zadanie wspierać nasze badania naukowe przeprowadzone na naszej katedrze i ten trening oparliśmy na wiedzy na temat witaminy B12 i jej niedoborów. i nasz system odpaliśmy na czymś, co się nazywa Retrieval Augmented Generation, to jest system, który przede wszystkim przeszukuje bazę danych w poszukiwaniu odpowiedzi na pytanie. Ten fragment, który może być wykorzystywany jako odpowiedź, jest przekształcony na kontekst i z tego kontekstu model językowy finalnie odpowiada na nasze pytanie. I naszym sukcesem jest to, że stworzyliśmy bazę danych prawie 1000 publikacji na temat witaminy B12, jej niedoboru i wpływu jej niedoborów na układy hematologiczne, układ krążenia czy też układ nerwowy, a także zaburzenia pigmentacji. To jest coś, czym zajmujemy się my na naszej katedrze szczególnie. Także dodaliśmy też informacje, żeby ta sztuczna inteligencja miała szerszy kontekst na temat też melaniny czy melanogenezy. I w ramach rozwoju naszego projektu będziemy także stale udoskonalać tą bazę wiedzy, dodawać tam najnowsze publikacje, aby te informacje były jak najbardziej zgodne z prawdą. I kiedy nasz system zostanie w pełni wytrenowany, będziemy mogli go ewaluować w takiej 5-stopniowej skali. Po pierwsze dokładność, czyli zgodność tych odpowiedzi z prawdą, kompletność, czyli czy wszystkie najważniejsze informacje zostają podane przez sztuczną inteligencję, search relevance, czy faktycznie korzysta z poprawnych źródeł, reasoning capacity, czy łączy informacje z wielu źródeł i resistance to information noise, czyli jak radzi sobie z sytuacjami, kiedy są pewne nieścisłości, jakieś sprzeczności w danych. I w celu ewaluacji, ale także treningu ułożyliśmy pytania, które podzieliliśmy na 4 kategorie. Pytania podstawowe, takie stricte faktograficzne, pytania integracyjne, które mają zadanie łączyć 2 lub więcej informacje, też pytania sprawdzające odporność, tak, wprowadzające pewną niejednoznaczność i pytania złożone sprawdzające wnioskowanie. I na dzień dzisiejszy nasza sztuczna inteligencja w odpowiedzi na pytania podaje źródła, w których istnieje prawdopodobieństwo, że odpowiedź na nasze pytanie się znajduje i to prawdopodobieństwo określone jest jako ten czynnik max resemblance. Jednakże w przyszłości chcemy, aby nasza sztuczna inteligencja odpowiadała w pełni na pytania i żeby te odpowiedzi były zgodne nie tylko pod kątem takim składniowym, ale także merytorycznym. Jeżeli taka sytuacja nastąpi, to będziemy przystępować do tej ewaluacji w 5-stopniowej skali. Na razie też głównie oceniamy pod kątem search relevance i z tego, jak sprawdziliśmy te źródła, czy te informacje faktycznie się tam znajdują, to tak, znajdują się te informacje, także mamy pewien kamień milowy w rozwoju naszego projektu. I na sam koniec pragnęlibyśmy bardzo podziękować profesorowi Sławomírowi Wilczyńskiemu i Instytutowi Inżynierii Biomedycznej Uniwersytetu Śląskiego w Katowicach za pomoc w takim technicznym wdrożeniu tego modelu oraz w jego treningu. Dziękuję bardzo, dziękuję również Państwu i zapraszam do zadawania pytań.
Bardzo dziękuję za tą prezentację. Thank you very much for your presentation. Do we have the question from the jury?
Yes, of course. Thank you for the presentation. This is just a basic step of your study. I have a question for you. We need the last field in the table. So could you tell us which kind of percent your work is in this AI development? In percentage, we need this data. And the second question is, you suggest that you observed publication from the period 60 years, yes? And about 1,000 articles.
Tak.
Yeah, look at the 1,000 articles. And you have any observation in the first step of this or not, related with the topic?
Dziękuję za to pytanie. Jeżeli chodzi o wkład naszego zespołu, to nasza praca głównie opierała się na szukaniu publikacji. Podzieliliśmy naszą pracę na odpowiednie kategorie i każdy z nas w tej obrębie szukał informacji na ten temat. Publikacje sprzed 60 lat pojawiały się w przypadku wpływu niedoboru witaminy B12 na zaburzenia pigmentacji, ponieważ jest to temat dosyć niszowy i te informacje, te publikacje tak, sprzed 60 lat często są kluczowe, żeby faktycznie zrozumieć dany temat. W większości nasze publikacje opierały się na przedział tak gdzieś 10 lat, tak? Czyli 2015-2025. Czytaliśmy głównie tytuły i abstrakty, tak? Też ważne jest to, żeby sztuczna inteligencja posiadała jak najszerszy kontekst, tak? I różne informacje, które są z pozoru może nie do końca związane ze sobą, też są przydatne w tej bazie danych, aby mogła mieć różne konteksty i porównywać te informacje ze sobą. Tak, można powiedzieć, że nasza część była merytoryczna.
I have a huge problem in assessment of your work because I'm not sure that your paper, your abstract fits into the our session because it used to be that review meta-analysis finds the answer or looks for the answer for the specific question. I know that for the purposes of your project, you created such question, but you are more likely to show the results of the AI research, right? So I don't know what to do, to be honest, because in my opinion, you should be qualified in the different session. So just only my...
Dziękuję bardzo. Zostaliśmy z naszym tematem naszej prezentacji tutaj zaklasyfikowani przez organizatorów. Ja też bardzo dziękuję za możliwość udziału w tej sesji. Rozumiem, że może te sesje nie do końca żadna z tych sesji nie jest w 100% odpowiednia tak dla naszego konkretnie tematu. Niemniej jednak bardzo dziękuję, że mogłem uczestniczyć w tej sesji.
Thank you very much. And now I would like to invite to the stage the author of the next presentation, Metabolic Profiles in Systematic Lupus Erythematosus, Primary Sjogren's Syndrome and Systemic Sclerosis.
Do we have the author of this work?
Okay.
If not, we will skip this work.
So the next paper is entitled Heart Rate Variability in Patients with Type 2 Diabetes.
Yes, I'm online.
Oh.
Yes.
Yes.
Okay.
Yes. Can you hear us?
Yes, I can. Can you hear me?
Yes, we can hear you and we can see you as well.
Okay.
Okay. So please just share with us your screen, your presentation.
Yes.
Yes. Just go full screen and we will be able to start.
Is it good?
Yes. Yes, it's very good. You can start. You have 7 minutes. Good luck.
Okay, perfect. Good afternoon, judges and every listener listening right now. My name is Sobruchi Angel Chidi KG, and today I'm going to be doing a presentation on heart rate variability in patients with type 2 diabetes. This work was done by myself and my colleague, Mariam Abubakar. I will start now with the background. And the background talks about heart rate variability, which reflects the time differences in heartbeats and is a sensitive marker for autonomic nervous system. And the heart rate variability, HRV, is also good for high levels. So it does like good adaptability, balance sympathetic and parasympathetic tones as well. But then in a case of low HRV, we have impaired autonomic control and also elevated cardiovascular risk. And then for my topic, type 2 diabetes, there's an impact on this. So it goes from chronic hyperglycemia to oxidative stress, toxic glycolation, and also damage in the autonomic nervous system. This diagram shows the cardiac dysfunctions, the peripheral circulations, as well as the parasympathetic dysfunctions and the sympathetic dysfunctions I'm going to talk about in the next slides. Yes. Now, for the mechanism of type 2 diabetes mellitus-induced autonomic neuropathy, it starts with hyperglycemic activation and with something called the polyol pathway, and this leads to accumulation of something called sorbitol and would cause direct damage to the nerves and also the neural blood flow. After this, we have activation of the protein kinase C, and this induces vasoconstriction in the blood vessels and also reduces the neuronal blood flow, especially in the vagal tone or vagus nerves, because it directly innervates the heart. This would in turn increase oxidative stress, free radical production, and also endothelial cell damage. All these mechanisms together will lead to axonal degenerations and then loss of autonomic controls. Then back again for the autonomic dysfunction in type 2 diabetes, it starts with the sympathetic overreactivity. So this is the first part, and then later progresses to something called parasympathetic failure. That would lead to something called resting tachycardia, orthostatic hypotension, as well as impaired BP regulations, in turn reducing the HRV. And like I said earlier on, HRV reflects the beats of the patient. So the time intervals between the beats compared to heart rate, which just shows the number of beats per minute. For the clinical importance, low HRV would show that T2DM is correlating with poor glycemic control. So if the patient has hyperglycemia or less control for the sugar levels or glucose in the blood, it could cause heart failure and even sudden cardiac death or something called silent MI. So it's very important that this situation is monitored and checked frequently to avoid such problems. In this diagram, you can see type 2 diabetes to autonomic nervous system, and then sympathetic nervous system is usually HR high and also BP high, and parasympathetic is BP low and HR low. But then when we have issues with the cardiovascular autonomic dysfunction, the HRV will become low in this and also causing orthostatic pressure, increasing the risk of cardiovascular events. And here are some consequences like myocardial ischemia, left ventricular remodeling as well, resting tachycardia, orthostatic hypotension, as well as blunted heart rate responses. For the methodology of study, we conducted a systematic review using 15 articles and then ended up reviewing 4 studies for our work. We had the database from PubMed, Embase, and Scopus. We identified 175 documents, excluding documents that were duplicated, and also databases that were not focused on HRV or T2DM, and also data that were not sufficient for our work, giving us the 4 studies to conduct our meta-analysis. For the results of our meta-analysis, we conducted this with the software comprehensive meta-analysis, and we conducted the meta-analysis on the 4 studies, like I mentioned earlier, and we assessed the heart rate variability in patients with type 2 diabetes. And our results from this study show that there's actually a very strong association with cardiac autonomic dysfunction and also reflecting a significantly reduced parameter for heart rate variability. These are the results of our study's standard mean and also the LF, that's the low frequency and high frequency powers as well. And the pooled results from our study show that there was a moderate to large negative effect size according to Cohen's criteria, supporting our conclusion that HRV is significantly impaired in individuals with type 2 diabetes mellitus. For the conclusion, I'm going to have some key points and takeaway for this work. Type 2 diabetes often causes cardiovascular autonomic dysfunction. I explained the mechanism earlier on, and it goes on frequently undiagnosed in patients. So you have situations where the patients may have reduced HRV, but then because of lack of monitoring or testing of this patient over time, they are going undiagnosed, and then we have issues like silent MI going on. And also, like I said earlier on, autonomic nervous system regulates HR and BP, that's heart rate and blood pressure. And then we have sympathetic and parasympathetic. And the disruption of the CAD would cause the reduction of HRV, that's heart rate variability, and also orthostatic hypertension. Consequences of this unmanaged issue will cause a rise in the risk of the myocardial infarction, even stroke, and then sudden cardiac death as well. And early detection and intervention of this situation can reduce major cardiovascular outcomes. Early detections and interventions like making sure that patients have their glycemic controls on a good level, making sure that lifestyle changes and modifications are done, like cessation of smoking and various other ways to help the situation. This is a list of the references for our work, and this is all for the topic today. Thank you so much for listening. Have a great day. Yeah.
Thank you very much. And before we hear the questions from the jury, please tell us about your contribution.
Yes, so I did mainly work with the articles. So I did study most of the articles and come up with this, like in the slide you see now for the systematic review. I also made this presentation while my colleague focused on the meta-analysis and the software used for that.
Thank you. So do we have any questions from the jury?
Work. Now, could you go back to methodology and checklist of PRISM? Yeah, thank you. Could you tell us what kind of articles, type of study is the most frequently in this review? What type of epidemiological, analytical, interventional, what type, what do you know, because you are specialist now?
Yes, I could answer this question. For our work, most of the studies, the titles of the studies were actually heart rate variability in patients with type 2 diabetes, to be specific, and the roles in the effect of cardiovascular risk. So most of the studies cover these areas, but there are also studies that just talked about cardiac autonomic dysfunction with type 2 diabetes, or even autonomic dysfunction as a whole, because sometimes it could not just be cardiac, it could be with the GIT causing gastroparesis. So, but for our study, it was most of the topics were focused on cardiovascular risk, on heart rate variability being lower.
Thank you very much. And now we are moving on to next presentation, the mechanism and role of BRCA mutations and PARP inhibitors in triple negative breast cancer. Do we have an author here with us?
I'm sorry, but Mariam isn't here right now. She had to go write an exam.
So I understand that the Mariam won't present the presentation right now, yes?
Yes, exactly. She will come at the end. She spoke to Mikhail yesterday, I believe.
Yeah, okay. So at this point, we will just skip this presentation and go to the next one.
It will be prevalence, characteristics, and clinical significance of os calcaneus secundarius, a systematic review.
Do we have the outcome of this work?
I think not. So the next presentation is titled The Implementation of Pericord for the Regeneration of Cardiomyocytes After MI as an Alternative.
Good morning to everyone. My name is Daniela Lopez. I'm a fifth-year student from Kyiv Medical University. I'm here to present our work on pericord cardiomyocytes regeneration. I would like to start with a small phrase. Nobody has ever measured, not even poets, how much the heart can hold. Now I will move to the background and a small introduction about our topic. Myocardial infarction is one of the leading causes around the world. Worldwide, there is 3 to 5% of the adult population suffering from heart attack. This causes tissue necrosis and the formation of a scar, so the heart is not able to pump blood. This progressively will lead to heart failure And the only therapy or treatment for advanced stages in heart failure, it will be heart transplant. Unfortunately, heart transplant has many disadvantages, as we all know. Three of the main disadvantages will be deficiency in donors. Second one will be the possibility of heart rejection. And the third one, but no most important, will be that there is not the ability of lifelong style or heart function. That's why we are here. Our main is to present how pericord can be effective as a therapy routine for those patients who suffer myocardial infarction. I would like to start with a small introduction about the stages after heart attack or myocardial infarction. There is three stages. The inflammatory phase, where there is myocardiocite death, proliferative stage, where the fibroblasts will start to form the scar, and the maturation phase, where this scar will be thicker and will be more stable. It's very important to remember this is not muscle, it's only a scar, and this doesn't help for the heart to pump blood and to work efficiently. Why we are here, we want to show pericord. Pericord is a cardiac patch, is a scaffold made from mesenchymal cells, specifically from Wharton's jelly from umbilical cord. Thanks to tissue engineering, now it's possible to create this type of patches that will simulate human pericardium. The main advantages of mesenchymal cell from umbilical cord and from pericord is the secretion of bioactive molecules, which can create new blood vessels, and this is called neovascularization. The second will be the mesenchymal cells from the umbilical cord. They have the potential to differentiate in many other types of cells. In this, in our study will be, or target will be the cardiomyocytes. And the third one, it will be immunogenicity properties. During this study, there were no need of immunosuppression drugs. From methods. From methods, we include from databases such as PubMed and The Lancet. There is only one study. The main study was carried out in Spain, in German's trial Spuchel Institute and University or Hospital. In this study, 12 adult patients undergoing surgery, coronary artery bypass grafting, they were divided in two groups. In the control group, undergoing only surgery, and the treatment group will include the implementation of pericord. This gives us a total number of 12, 5 patients in one and 7 patients in the other. The participants undergoing the surgery, and they were applied 1 or 2 pericords directly in the transmural infarcted area. The number of pericords that we supposed to use, it will depend on the size of the area of the heart. Of course, it was used with surgical glue. The results. The results of pericord were very helpful. We can see left ventricular ejection fraction was stable over 1 year. We have to remember this study was carried out from 2020 to 2023. Safety and tolerability. The patients show very good safety during the implant. Also, 5 who received the pericord were the control trial didn't show any type of transplant rejection, showing the biocompatibility and the immune response modulation. The secondary outcomes, where we talk about cardiac function or quality of life, we couldn't measure these. We couldn't measure these outcomes because this study it was started in 2020. So this is one single double-blind trial. As a conclusion, we can see in this double-blind trial study, we can conclude that Pericor shows a favorable safety profile. We didn't use any type of immunosuppressive drugs or immunosuppressive therapy in any of the patients, any of the 12 patients, and these findings suggest that Pericor may play a role in the cardiac society, increases the possibility of replacing cardiac transplant in the future, but furthermore studies we will need or more bigger trials to see these findings and to prove that maybe heart transplant can be another option to use Pericort. Here we can find the references that we use. We use 4 main articles, 1 single study from 2020 to 2024. Thank you so much for your attention, and I will be glad to hear all your questions. And also I would like to invite my co-author so she also can be part of the discussion.
First, just say about your contribution to this research.
So my main contribution of this study was to identify which articles were able to show the results of the Pericort. Unfortunately, it's just one single study. So we couldn't find that much information, but it was promising and it was very interesting for us. That's why we use it. For explain why we should think about another therapies for after heart failure. And my co-author here, Helin Uzun, she is from Turkey. I'm from Ecuador. We both are in 5th year in Kyiv Medical University. If you have any question, we are glad to answer.
My question is related to the number of participants, because you said that results are very promising. And I always have the issue with the sample size in this case, even if it's a clinical trial. So the measurement error could be so large that the effect size could be, can create such promising results. So either I have a doubt, even if your presentation, because your presentation was really great. In English, you were standing in front of us, so I wasn't watching your back, so that was really great. I have an issue, even if the quality of your presentation, the work that you've done is really good, right? So don't be angry if I will assess you a little bit lower because the number of papers, etc. Right?
Do you know it is expensive Pericort if you compare this type of treatment with the classic method?
Yes, I know Pericort promising to not be that expensive because of the facility to obtain the mesenchymal cells of the umbilical cord. This is a non-invasive collection. So what they are creating is using the tissue engineering, which is kind of expensive nowadays. But they are trying to perform or to create it accessible for most of the patients, because the main goal here is to replace heart transplant, which is expensive, which is also people have to wait a lot of time. So I think the main objective, the main advantage of it will be accessible for most of the patients after myocardial infarction.
And also it's easier than the normal heart transplantation because there is no hurtful for patients, because as we talk about, it's from umbilical cord, so there is no heart harmful for mother or as a baby, so it's much better than the heart transplantation, and it will be much cheaper. Thank you. Thank you.
Something very interesting that we found in here was the regeneration of cardiomyocytes, which we didn't find another study about it. So it was very interesting for us to perform this study.
Maybe you develop this.
I hope. Maybe one day. Thank you. Thank you very much.
Now we are moving on to presentation number 16, robotic PCI and clinical effectiveness. Is newer, always better, a systematic review. Yes, number 15 is out. And then we will move on to number 2 and 3 and other ones.
We are not coming back to that. We're not coming back.
Okay, yes.
We just erase that.
Pilocik i od razu na końcu. To jest czerwona Nie wiem, czy utrzymasz w rękach wszystko.
So good afternoon. My name is Krzysztof Żerdziński and I would like to share with you the results of our study titled Robotic PCI and the Clinical Effectiveness Debate, Is Newer Always Better? As a beginning, robotic PCI was introduced to reduce radiation exposure and improve procedural precision. There is several robotic PCI models available now, but no studies have directly compared them head-to-head. This gap led us to ask a key question: how robotic models perform both against manual PCI and in comparison to each other. We conducted a systematic review and network meta-analysis following PRISMA and Cochrane guidelines. We screened 3,735 records from 5 major databases, PubMed, Scopus, Embase, Web of Science, and Central, with no filters or language limits. We extracted data into an Excel document, and I can say I contributed in data extraction and the screening process, in the bias assessment and the writing. We focused on 7 endpoints, which was procedure time, fluoroscopy time, clinical success, contrast volume, major adverse cardiovascular events, dose area products, and radiation error karma. Bias was assessed using Newcastle-Ottawa scale, and all the studies were rated between 7 to 9 stars. I mean every our included studies, which indicate generally high quality, so low level of risk of bias. Two statistics we used are software inversion for free with random effects models. We used odd ratios for binary outcomes, and we used mean differences for continuous ones along with 95% of size. Heterogeneity was measured by I-squared, and platform ranking was based on p-scores. Across 9 studies, we included a total of 3,650 patients. 2,674 underwent manual PCI and 976 underwent robotic PCI using three platforms: CorePath 200, CorePath GRX, and RNS. Most of our patients were male and presented hypertension. On this slide, you can see 4 of 7 our endpoints, and none of them demonstrated statistically significant differences between robotic and manual PCI in control. The only statistically significant finding was for radiation error karma, where model of CorePath GRX presented a significant reduction of radiation at the level of minus 610 milligrays. Let's take a look at the summary of p-values. Values closer to 1 indicates better intervention, as we highlight the best results for each endpoint. And as you can see, in every aspect, our PCI outperform manual form. And model of CorePath GRX was the best model through all of robotic PCI. Looking down below, the partial manual assistance, which means procedure started on the robotic PCI and went to semi-manual form, in the case of from 11 to 36%, but full manual conversion was occurred below 7%. To summarize key findings of our study, radiation air karma was significantly reduced with COPAV-GRX. There was no significant difference in other clinical outcomes. P-scores were generally higher for RPCI systems, but no relevant in most of clinical outcomes. As I mentioned before, manual conversion rate through RPCI into full manual form was under 7%. Key limitation of our analysis, analyzing 5 of 7 endpoints, was high heterogeneity, exclude radiation air karma. Going through other limitations, so first of all, we excluded patients with severe cases of coronary disease from our study. All studies were non-randomized, that's why we used a Newcastle scale. There was no direct comparison between robotic platforms in exact same settings. There was small sample size in some arms, especially for RNS model, which was mentioned only in one study. And data on long-term cost effectiveness for now is so limited, so we should focus on it in the future. To conclude, RPCI improves operator, there is a mistake. RPCI improves radiation safety to the patient significantly with CORE-PAV-GRX. There is no significant advantages in other clinical outcomes. And given the similar effectiveness but much higher costs, a comprehensive cost effectiveness analysis is needed for now to justify broader adoption. And future trials should focus on a randomized form and real-world cost analysis. Thank you for your attention, and I will invite you to the discussion, and I invite my co-author there.
And of course, if you can say your contribution to this.
I mentioned during the presentation, yeah. I took participant in data extraction, in writing, in screening, and risk of bias.
And may I have a question? Why did you choose R software to analyze your data, and who really assess?
I assessed risk of bias. I didn't provide analysis. My colleague can say more about this.
This is biostatistic, yeah?
So I can say that R software biggest advantage is that it's relatively simple and it's free. but that software is free and offers very comprehensive libraries for the statistical analysis, which allow to perform a complex analysis.
Do we have any other questions? If not, thank you very much for the presentation. Thank you very much.
Było to ostatnie?
So, ladies and gentlemen, we have to go back to the presentation that was second in our list. The presentation titled Riboflavin and Hypersine Mediated APTD as Alternative Treatment for Candidiasis, a systematic review. Please welcome the author of this presentation on the stage.
It's pretty good. Good afternoon, ladies and gentlemen. Today I'll be presenting a systematic review about antimicrobial photodynamic therapy for oral candidiasis done at the Department of Periodontology in Zabrze. Oral candidiasis is caused by Candida albicans, of course. It's in the area of rising antifungal resistance to antifungal drugs with new multi-drug resistant strains. We have to use alternative methods of combating this infection. Antimicrobial photodynamic therapy with riboflavin and hypericin are suggested alternative therapies. They are becoming more explored because these are natural photosensitizers. These are substances that dissolve naturally and are tolerated well by the body. We conducted a systematic review according to the PRISMA guidelines. We registered the systematic review in Prospero. The search identified 16 studies from the past 10 years. These included both in vitro and animal studies. We then extracted details about the light sources, the lasers used, or the diodes, LEDs, etc., the photosynthesizer concentrations, and antifungal outcomes from these studies. What was our focus question? So we used the PICO guidelines to formulate our focus question. We basically wanted to know if these new photosensitizers are as effective at eradicating, reducing Candida infections, for example, CFUs or log data, compared to traditional methods such as drugs, so antifungals, or blue light alone, or other pharmacological interventions. For our risk of bias assessment, because of heterogeneity in the included studies, we developed our own risk of bias criteria based on the Cochrane Handbook for Systematic Reviews. These included assessing the completeness of data, the source of bias that could potentially impact the conclusions, how well the conclusions were formulated, and how accurate the data was from a microbiological as well as a clinical dentist perspective. The 16 studies are shown here. As you can see, there's significant variety of geographical regions. However, this did not form part of our conclusions. To summarize the things that we found out, both photosensitizers showed significant antifungal activity, which, as I mentioned, was measured by reductions in the number of organisms, the CFUs, as well as the clinical isolates included, and clinical in vivo trials showed clinical improvement. Riboflavin was activated by light in the blue range. Hypericin was activated most efficiently by light in the yellow or orange range. It was effective against fluconazole resistant strains, which is one of the most important aspects of our question, whether it was effective against these multi-drug resistant bacteria. And biofilm eradication remains difficult. However, it's more effective than locally administered, topically administered fluconazole. So to conclude, riboflavin and hypericin APDT are promising. They are biocompatible, so they do not have side effects that artificial substances, whether used topically or injected, have. However, because the vast majority of these studies were in vitro trials, further clinical trials are needed to extrapolate this and translate this conclusion into a clinical setting. This is promising. Our systematic review aimed to encourage these studies. The problems: why did we not conduct a meta-analysis? That was because protocols. These were completely different studies. They had different laser parameters, different light sources, different concentrations, and different means of administering the photosensitizer, which made analytical statistical analysis difficult. As I mentioned, mainly in vitro data and protocol variations, which made it very difficult. As I said previously, this has enormous potential. However, future clinical and standardized protocol trials are needed. This publication was published in Pharmaceutics And so far it's received 7 citations, mainly by researchers in dentistry, which I included this to give you some context on the relevance of the study. So after being published in January, I think it has shown enormous interest.
Thank you very much for this presentation. We will just continue the discussion. Do we have any questions from the jury?
A short question.
Yeah.
Why you suggest that mainly so all of the publication is made in vitro? Why we haven't data in human beings?
Well, this is mainly because of logistical implications. These 2 sensitizers, especially hypericin, is not used commonly. It's not available in every country, so this limits its use worldwide. The hypericin, which is effectively activated by the PDT, is quite expensive as well. So this area is quite niche. Not many people are using APDT in dentistry. This is a very, very novel thing. I included the studies from the past 10 years, but this range does not show the fact that most of the studies, only one was from 2016, but most of the studies were from the past 3 years. So this is a very, very novel thing. It's promising. This is why I wanted to show it as well. I also included that slide showing that there are 7 citations on this in 3 months. So I know this perhaps for you, I don't know if you're a dentist or not, perhaps not, but it's a very promising and new niche thing. So this is why it doesn't have the clinical trials to back this. But the results are very promising, and I hope to see more. I hope that our systematic review influences researchers to conduct clinical trials. I know Professor Viench at the Department of Periodontology has several PhD students who have considered using this. So we will see in the next few years whether this will be used. When it comes to my input, of course, because of we use PRISMA guidelines and Prospero guidelines, there were 3 reviewers who independently screened this, but I extracted the data. I did the risk of bias assessment first. I was the first author in the publication, and I formulated the tables as well as I did all the formal analysis. So that was my input. Thank you.
Thank you very much. And with that, we will just go to the second. The third presentation of the session, therapeutic potential of cannabidiol in disorders of the upper quarter, a systematic review, also presented.
Coś się nie łączyła? Mam 12. 7. 7.
So my second presentation, it was also a systematic review conducted with a similar methodology, of course, changed to accommodate this topic. We try to see how effective CBD is for refractory TMD, so temporomandibular disorders which are difficult to treat pharmacologically, through physiotherapy or through conventional methods. Temporomandibular disorders affect not only the actual temporomandibular system, you can have heterotropic pain, and trigger points, which cause pain in other regions of the upper quarter, broadly speaking, the head and neck region. We have seen temporomandibular disorders significantly affect people's lives, causing neurogenic inflammation, which causes CNS-mediated chronic pain. New strategies have been applied to TMD disorders and are constantly being reviewed. One of the most promising strategies is using CBD. Anti-inflammatory, muscle relaxing effects, and it's an analgesic. We wanted to see how many studies, especially clinical studies, have been published in this regard, and to see what its efficacy and safety is in these also dentistry-related outcomes. Our risk of bias was once again based on the Cochrane Handbook of Systematic Reviews guidelines, and it included the basic questions about the bias, the robustness of the methodology, as well as the intent and worth of the study. We searched PubMed, Embase, Scopus, as well as the Cochrane Library. We registered this study again in Prospero, used the PRISMA 2020 guidelines, and this gave us 10 studies, which were both preclinical and clinical. As you can see, the fact that only 10 studies exist on this in this specific setting of TMD and upper quartile disorders shows that this is also quite an emerging field, and I think through this presentation and through this systematic review, I wanted to show this and also guide research. Most of these were animal studies, and only 3 were randomized. But most found that the randomized studies concluded that CBD did reduce pain, also neurogenic pain, so pain modulated rather than by nociceptors or proprioception, but pain which was induced chronically through efferent fibers by the CNS. And also it cured, it reduced muscle activity, decreased the input into the CNS, also decreasing the output, which resulted in control of bruxism. Topical and intraoral formulations were most effective. Once again, these studies, because this is a niche area and an emerging topic, they had significant variability in doses and routes and study designs. To conclude, CBD is a promising adjunct or alternative therapy for the current usage of plates, etc., in oral dysfunction. It's safe and with localized application, and I think further large-scale trials are needed. The limitations of our study was, of course, study heterogeneity. This was rather because it's also, as I frequently mention, it's a niche and new aspect of treatment in dentistry, and it's a new formula and new protocol which has to be further explored. A lack of standardized measures and short follow-up periods also hindered the utility and the robustness of our conclusions. Clinical applications are, of course, to use CBD where conventional treatment fails. Topical and intraoral CBD shows particular promise, and an integration into a multimodal holistic TMD management as an adjunct to conventional therapies might be a good application of this in the future. Thank you.
Thank you very much for your presentation. Do we have any questions from the jury? The question...
Mm-hmm.
It's the way the same presented, so
yes, so I was thinking about not presenting this, but I think my previous study was much better. The use of natural photosensitizers in dentistry and in treating OPMDs. So this is also laryngology as well. Treating pre-malignant lesions, treating squamous cell carcinoma. This has real potential and reduces the side effects of conventional photosensitizers, which are artificial and often don't degrade very well. So I think my previous study was more innovative, and I think I don't know how much you know about dentistry, but I think this is a very, very important area of research for dentists. So I just wanted to say that for beginning. Thank you for your questions.
Thank you very much for this presentation. And we will just go back to our last presentation presented online. The mechanism and role of BRCA mutations and PRRP inhibitors in triple-negative breast cancer. Do we have the author online?
I'm here.
Yes, we can see you. Do you hear us?
Yes, I can hear you.
Yes, we can hear you. So just show us your presentation.
Okay.
The information for the judges, this is the presentation number 12. Okay. So, Mariam, please go. Please go full screen and we can start, okay?
Okay, I'm about doing that now. Yes, so can you see the presentation?
Yes, we can see the presentation.
Okay.
You have 7 minutes. Good luck.
Okay, thank you. Hi, my name is Mariam Abubakar, and with my colleagues Nancy and Sopuchi Angel Chidikeji, we have a presentation, the mechanism and role of BRCA mutations and PRP inhibitions in triple-negative breast cancer. So firstly, we can see that breast cancer most commonly arises in like the ductal epithelium, and then we have like different ways. Sorry. So here we have the luminal A, we have type hormone receptive positive. Luminal B, we have the HER2 positive. Basal-like, we have the negative, and then we have the HER2 positive for HER-NH. And we have the pink ribbon, which symbolizes the breast cancer awareness. And for the triple negative breast cancer, we can see that we have a subtype of the breast cancer, and it normally lacks progesterone receptors, estrogen receptors, and epidermal growth factor receptor 2. Also, we can see expressions of CK5, CK14, HER, and we have 4 types. We have like the basal-like immunosuppression. We have mesenchymal, which deals with the signaling pathway, immunoregulatory, and then the luminal androgen receptor subtypes. So for here, we're going to talk about the BRCA, which is known as the breast cancer gene. And in this particular case, we have 2 types, which is BRCA1 and BRCA2. BRCA1 is found in chromosome 17 and BRCA2 is in chromosome 13. As we can see, they are both like autosomal dominant inheritance, and then we get that from both parents as well. So basically having the BRCA2 genes, they are tumor suppressing genes and DNA repair proteins. And then they can also cause like other types of cancers like pancreatic, ovarian. We've known to see them that they can cause like prostate cancer as well. And then they come together with like RAD51 to form like a homologous recombination fixing like the DNA. And then for the PARP inhibitors, as we see here, we have the olaparib, we have the talazoparib, and then we use basically 5 DNA pathways for fixing. We have the nucleotide excision, we have the base excision, single strand break, and then we have the double strand break as well. But mostly we use the BER when it comes to BRCA and the PARP as well. So here we can see using the DSB, which uses platinum agents, and the PARP1 inhibitor blocks the poly-ID ribose polymerase from forming causing single strand breaks as well. So the PARP blocks, and they normally have a form with sodium, and then once they do that, they tend to form climb into the system and fix. They have 5 steps. We have the cleaning of the DNA, we have the ADP depilation, which also helps to like close and clean it and form into a new DNA strand. And then for the methodology of studies, we see here that we have like first 5 studies included in our review, and we took it from 100 articles as well from like different databases like PubMed, Embase, Science Direct. And here we have the results of the review, and then we have the progression-free survival. The meta-analysis shows that in patients that were treated with PARP, olaparib, talazoparib, you see here that compared to standard therapies, we have the hazard ratio, which was 0.56, which is 95% confidence interval. And then we have like the P, which is greater than the P value 0.001. But overall survival, we can see here that the PARP, they showed like enhanced improvement compared to chemotherapy. And then the overall response rates, we see here that they are significantly higher in the PARP inhibitor group. And we have like a safety profile, which means that basically we have like events such as fatigue, nausea, and hematologic toxicity. For the conclusion, we use synthetic lethality for the PARP inhibitors. And synthetic lethality means that 2 agents coming together to work and to fix it. But at the same time, the 2 agents tend to like destroy the particular cells. And so we normally use like PARP to fix by doing single strand breaks. And during the replication stage, they help to like destroy toxic by the double strand breaks, which can be BRCA1 or BRCA2 and leading to this. Well, the FDA gave approval for olaparib and talazoparib using, we have 2 trials, which were the Olympiad and Embraca trial. And recently in December 2019, it was presented to the San Diego Symposium and in Brazil, and then they spoke about it and they were given like the go ahead to go about the phase 3 and phase 4 in figuring out that these 2 are much more better than chemotherapy. So thank you for listening.
Thank you very much for your presentation. Do the jury have any questions? If not, thank you very much for your presentation. And we will try to connect again with the author of the work number 7, sildenafil as a cause of a sudden cardiac death, factors and clinical circumstances characteristics. Susanna, do you hear us? Do you see us? Yes. Let's try again to see your screen. And right now we can see your screen. Please just go full screen and start. You have 7 minutes. And ladies and gentlemen, that is for sure the last presentation of that day.
Dear jury and the audience, my name is Zuzanna Czeczelewska. I represent Medical University of Lublin. In this presentation, I will try to focus your attention on the responsible usage of well-known for erectile dysfunction treatment, sildenafil, also known as Viagra, and show its potential cardiovascular risks. Before that, let's begin with some basic information. Sildenafil was originally dedicated for the treatment of hypertension and angina. However, now it's mainly used for treatment of erectile dysfunction. This is it belongs to the group of phosphodiesterase type 5 inhibitor that enhances the effects of nitric oxide, leading to vasodilation, lower blood pressure, and eventual improved blood flow. At that point, it is important to mention that sildenafil should not be combined with other blood pressure lowering medications, because especially nitrates, due to the excessive hypotension. The other key fact is that sildenafil has been available without prescription in Poland since 2016. This over-the-counter access increases the uncontrolled and excessive usage. Our interest in the topic began during the forensic medicine classes when we came across 2 cases in our region of sudden death following sildenafil usage. The circumstances of death different from each other's. However, in both autopsies, it was revealed hyperemia of the left heart, and in both cases, it was opinioned that it was sudden cardiac death. And here we've got a brief definition. Sudden cardiac death is unexpected cardiac death within 1 hour from the start of the symptoms, regardless of the heart diseases. These two cases inspired us to explore the topic further. To understand the scale of this problem, please imagine that in Poland, there are around 1.5 million men over the age of 35 that suffer from erectile dysfunction, and unfortunately, this number increases with age. Studies says that 9 out of 10 patients decide to self-medicate without the prior consultation with a doctor, what is related with a general availability of this medication. On this graph, you can see a significant growth of sildenafil sale, what is related with effective commercial. Considering the size of the exposed population, even rare complications are prevalent. That's why we decided to continue our research and identify factors and mechanisms that may lead to possible cardiac death. For this, we used PubMed and Scopus database, focusing on words sildenafil, sudden cardiac death, myocardial infarction, with a range of years from 2010 to 2025. Moving to the results, it eventually turned out that sudden cardiac death among patients that use sildenafil, well, it happens rarely, but is regularly described worldwide. And most literature focused on positive outcome of the sildenafil. Nevertheless, there are only single reports of sudden cardiac death. And now let's get to know what those all reported cases have in common. First of all, let's focus on age group. The most affected group were men aged from 50 to 60 years old. There were also mentioned men in younger and older groups, but these were only singular cases. Second, circumstances of death. In most cases, death occurred shortly after the sexual activity. Some cases happened even during the intercourse. Both case situations may be related with the physical activity. Moreover, it was also mentioned that it occurred death after taking sildenafil straight away. The third point is the most important, I think, because it relates with comorbidities. Most victims had fundamental cardiovascular diseases, such like here listed. These pre-existing conditions seem to have pivotal contribution to fatal outcomes following sildenafil usage. Fourth, the dosage. In many cases, the reported dose was 50 milligrams, which is a typical amount, a typical dose. However, some cases involved overdose. We had an article where there was pointed 600 milligrams of sildenafil used. Also, it was reported repeated use of multiple doses. Fifth, the other substances. Sildenafil was very often combined with nitric acids, alcohol, or drugs. Fifth, which is the mechanisms of death. Such sudden cardiac death may happen due to the myocardial ischemia, cardiac arrhythmias such as ventricular fibrillation, or severe hypotension due to the drug interactions. In this way, we have a full table of potential risk factors that patients have in common, should be cautious about, but please have in mind that those are rare situations. To conclude, the ability of sildenafil increases without the prescription increases the unsupervised usage. However, sildenafil is safe when under proper assessment, proper medical supervision. When risk factors are present, unsupervised use of sildenafil may lead to higher risk of serious complications, involving even the most serious one like sudden cardiac death. And here it's crucial to assess individual risk, supervised treatment, and all about educate the patients. Thank you very much for your attention.
Thank you very much. Do we have any questions from the jury? If not, thank you very much for your presentation. And with that, we will end our session of the systematic review number 2. Ladies and gentlemen, all the submitted papers have been presented. We congratulate all the presenting authors and the participants of this session. At this point, I would like to ask the jury to give me the cards and we'll verify them. For the jury, thank you very much for your hard work during this session. I know it was long, almost 3 hours of your giving your great knowledge about the systematic review and all medical fields. I know it wasn't easy. It was the hard job, but thank you very much for what you do and for what you gave to our participants. Thank you very much. And for our yes, great applause. Yes, of course. Maybe
for all participants, dear medical students and other medical sciences students, it is important using meta-analysis. It will be useful, but could you remember that basic measurement, basic study, contact with your patient, observation of your patient, it will be the best way to effective treatment. Could you believe me?
Thank you very much for those vulnerable words. And ladies and gentlemen, thank you. I would like to invite you for the decoration and closing ceremony of this conference, which will be held at A3 Hall on 9th of May at 5 p.m. You are also welcome to join us for the after-sing party at DSO Club at 9 p.m. For more information, you can find it on our Facebook and event called Carlos from Sync 2025. Thank you very much for this session, and I think we are over. Thank you very much.